Hey guys, so today we're going to be talking about a topic that you guys are probably not quite as familiar with as you were with the anxiety disorders and OCD. Today we're going to be talking about somatic and factitious disorders. Broadly speaking, these two categories of disorders relate to physical symptoms. And so, one of the reasons that I like to highlight this particular chapter in this class is because a good number of you guys are kind of pre health in nature and thinking about healthcare related fields. And so, we're going to be talking about um, mental health reasons, I guess, for physical healthcare like symptoms. So, in a nutshell, we're going to be talking about why some people go to the doctor, reasons that are atypical and that you might not really think of. For instance, sometimes people go to the doctor because they have a difficult time explaining very real physical symptoms. Some people go to the doctor because of a very persistent worry about their health. Some go to the doctor as an attention seeking type of behavior, and some people go for external reasons like to get out of work or school, avoid military service, to gain access to drugs, or in some cases to avoid criminal prosecution. So, we're going to be talking about some diagnoses that go alongside these reasons. First up, we have conversion disorder. Conversion disorder is a really funky diagnosis. The hallmark symptom is altered voluntary motor or sensory function, meaning that the person has lost their ability to use part of their body from a mobile perspective, so the person feels paralyzed potentially, or has lost one of their senses. So they're experiencing blindness, deafness, numbness, or maybe even have a dysfunction with respect to the sensations of taste or smell. But the kicker is that labs do not fully, at least, support an underlying neurological or medical condition. So the person's going to the doctor with very real symptoms. That's one of the takeaways here is we're talking about real symptoms, not fake symptoms. So the person really feels paralyzed or numb or cannot see. But when physicians are doing labs to figure out what's going on, they can't really find a neurological or medical condition that fully explains what's going on. At this point, I would suggest pausing to watch the clip entitled Conversion Disorder that I've linked you guys to on As You Learn. It's a really neat video that goes through three different cases of conversion disorder, three women named Kimberly, Karen, and Suvencha. And what's nice about this video is that you get to see three different perspectives of conversion disorder, three different types of symptoms. These women also highlight some of the different causal paths to conversion disorder. In particular, you guys will see trauma, represented in this video well. You will also see psychological distress converting to physical symptoms. And Karen does a really nice job of describing that last one. She basically talks you guys through the idea that, like, when she's really sad or angry, she doesn't really break down and cry. But that later she'll kind of seize and have physical symptoms as a representation of those emotional sensations. A third potential cause that isn't really highlighted in this video quite as much is heightened sensitivity. And I will actually share with you guys a personal anecdote that, while is not conversion disorder, this experience of mine, I guess, made me think of conversion disorder and helped me kind of relate to this diagnosis a little bit more. So, what was happening was I had a headache, and this was, I don't know, like maybe 5 years ago. And I opted to just kind of drink some water and go to bed. But I woke up at maybe 3 or 4 in the morning and my head was still pounding. And so I decided to get up and eventually take something for it. And, I think I had maybe one ibuprofen left. So one 200 milligram acetaminophen tablet, and I took it and was like, "Ugh, like, why do they even bother doing that? Like, that's not going to do anything." And I've taken that medication on an empty stomach before. I know you're not supposed to, but I went back to bed and I just stared at the ceiling, and all I could think of was, Dad always told you not to take NSAIDs on an empty stomach or else you'll get an ulcer. And like I said, even though I've done that before, it never bothered me. But for whatever reason, on that early morning, I just could not get that thought out of my head. I was so fixated on the idea that I was going to give myself an ulcer, and I was just tired and delirious and did not get up to go to the kitchen to eat something, and just sat there and thought about that really terrifying thought for about an hour, to the point that I actually did make myself sick. And that had nothing to do with the medication that I took. That had everything to do with my heightened sensitivity to my GI, to my stomach, and just my very strong belief in this symptom, to the extent that I ultimately manifested it. So that's kind of an example of how heightened sensitivity can potentially convert to a conversion disorder. One potential clue, if you are working in a medical setting, as to conversion disorder possibly being present, is if a patient comes in with symptoms that do not adhere to what we know of human physiology. A great example of this is glove anesthesia, which the graphic on the screen represents, where a person feels um, numbness beneath the wrist. So the wrist kind of acts as this like delineation point where the person cannot feel anything, or doesn't feel pain beneath the wrist, but then has full sensation above the wrist. Based on what we know of human physiology, we know that nerves run vertically. And so if you had nerve damage, it's more likely that you would have numbness along your thumb or the side of your hand, but the numbness wouldn't just happen at that horizontal plane along your wrist. There's no physiological reason for that symptom. And so the only explanation at that point would be mental, basically, that your brain is creating the symptom. So, in a nutshell, these are very real symptoms, but ultimately there's no underlying cause. And so the explanation is that the brain ultimately is kind of creating these symptoms for the patient. Another reason a person might go to the doctor is illness anxiety disorder, more popularly referred to as hypochondria. So with this one, hypochondria is the phrase that most of you guys are familiar with, but you should know that the clinical DSM diagnosis is illness anxiety disorder, and so I'm going to expect you guys to be familiar with that term for this class. Basically what it is it is a preoccupation with having an illness. Symptoms are either absent or mild, so it is possible for a person to have some symptoms, but it's going to be like, I don't know, maybe a faint freckle that someone is interpreting as being a cancerous mole. Or alternatively, the person has absolutely no symptoms, but is very preoccupied with the idea that they're sick. And this typically doesn't go away despite reassurances from the internet or loved ones or doctors that, you're fine. This one used to be considered with the anxiety OCRD disorders, because there is very high anxiety with this group. We've got excessive health related behaviors, which kind of function almost as like compulsive types behaviors. Things like body checks, WebMDing a lot, going to the doctor persistently. Some people also tend to err on the other side of the spectrum in terms of just kind of avoiding all of that altogether. So sometimes I like to kind of present this disorder from that perspective, because it does function very similarly to an anxiety disorder or an OCRD, and makes it a little bit more like those things versus like conversion disorder. But as of this edition of the DSM, it is being included in the somatic symptom types of disorders. Another disorder that I want to highlight is something called factitious disorder. Factitious disorder is when a person is faking a physical or psychological symptom, despite the fact that there is no injury. So the person is not sick physically or psychologically, but they are pretending as if they have symptoms. So the person could do this in a way that does not injure themselves. So they could do this in a non-injurious way, such as putting small pieces of glass into their urine and then presenting a urine sample as if they have kidney stones. The person could intentionally injure themselves in order to present as sick. So the person could actually consume like rat poison or something like that. So the person ends up really being sick in that situation, but it's a self-induced sickness versus being authentic or genuine. The person could also fake psychological symptoms. So, faking a difficulty concentrating, for instance, to get an Adderall or Ritalin prescription. This person is presenting as ill, impaired, or injured. The kicker here is that there is no external incentive. So the person is faking these symptoms purely for internal reasons. If the person is presenting for an external reason, like to get an Adderall or a Ritalin prescription or to get out of school or something like that, then we would label that person as having malingering behaviors versus factitious behaviors. So factitious is exclusively internal reasons, which we'll talk about on the next slide, versus malingering is any type of external reason. There are two types of specifiers that we may use in terms of describing people with a factitious disorder. A factitious disorder can be imposed on the self, meaning that the individual is presenting as sick, or imposed on the other, sometimes referred to as by proxy, meaning the individual is presenting someone else as sick in order to appear in the caretaker type of role. Colloquially, this one's referred to as Munchausen syndrome, so you may be familiar with that term. But again, like hypochondria and illness anxiety disorder, we're going to be referring to this one as factitious disorder in this class. Why? Ultimately, the answer boils down to attention. This person is attempting to present themselves in either the sick role or the caregiver role to either get attention as a sick person or as a doting caretaker taking care of someone who is ill. Typically, this ends up being associated with a history of trauma, a history of illness or neglect, and many are unaware as to the reason why. So many people either, were sick persistently when they were younger and learned that this is, how you get attention, or maybe were neglected, maybe not even intentionally neglected. Like you've got really busy parents who are never around and they only take time off to play with you when you're sick, or not play with you, but spend time with you when you're sick. Some people, again, have trauma histories too and kind of learn that they can gain attention through one of these two roles. But again, many are unaware as to why. So this may seem obvious to us as professionals, but this link is not super clear to the individual with factitious. This person is so desperate for attention oftentimes that they are willing to undergo dangerous or invasive diagnostic or therapeutic procedures. So this person is willing to get biopsies, is willing to take medications that could potentially make them sick, because they don't really have the thing that they're presenting with. So this is a very, very desperate need for attention. For those of you thinking about working in a healthcare setting, I will point out that that there's a greater likelihood of these folks showing up in an emergency department during the evenings and on weekends because it's known that these are times when more junior staff are working. And so people know this and will intentionally kind of present at these times, hoping that there's a greater likelihood to fool the junior staff member. The costs of this include financial, because obviously you are racking up healthcare bills when you don't really need to. You may be making yourself permanently sick, depending on what you're doing in order to fake symptoms. And death may even be an outcome in some more severe situations. In fact, about 6 to 22% of children die via the by proxy type. One note that I'll throw out there is in relation to childhood sexual abuse, or CSA. The reason that I like to talk about this is because typically when I ask classes like, why do you think that someone might do this? Attention is an answer I get a lot. And sometimes people will bring up the idea of childhood sexual abuse. Like, that seems to be everyone's favorite answer for everything, or anytime an adult does something that seems strange and unexplainable, it's like, well, the most horrific thing had to have happened to that person as a young child in order for them to be doing that as an adult. And childhood sexual abuse always kind of comes up as the answer. At the end of the day, there is a link between somatic symptoms or concerns, meaning a link between disorders like conversion, illness, anxiety, factitious, and childhood sexual abuse. But all of these links are correlational in nature versus being experimental, meaning that we do not know whether or not that link is causal. And in fact, there are several third variables that could account for that link, such as conflict, hostility, or growing up in an aggressive family environment. These are things that overlap with childhood sexual abuse. Same thing with cold, rejecting, neglectful parent child interactions, and chronic interpersonal stress. And at the end of the day, more experimental or quasi experimental research indicates that it's actually the hostile and rejecting family environment that is causally associated with somatic complaints versus specifically childhood sexual abuse, particularly when a father is involved in the equation. Childhood sexual abuse instead is a general risk factor for adult pathology, meaning that if a person has a positive history of CSA, that simply predisposes them to any DSM diagnosis in adulthood, not specifically a somatic complaint. If you're looking for a specific family predictor of somatic complaints, that would instead be the hostile and rejecting family environment. All right, so this was a short lecture, and that is all that I have for you guys.